The NCCN guidelines have changed. The NCCN guidelines get updated based on the new data, and treatments get integrated into the NCCN guidelines when the data become available, whether it's at ASH and the data has been presented at ASH, or it's trials that have been reported in the literature. And the changes and evolution in the NCCN guidelines recently have been reflective of the trials that have reported out. So RESONATE-2 was the data that supported in the NCCN guidelines having ibrutinib in there as a Category 1 first-line treatment. It's also in there as a Category 1 treatment for relapsed patients. So the trials are up, the NCCN guidelines are updated as the trial data become available. We update them twice a year, after ASH and then in the late spring. And as I mentioned, they're reflective of what's happening in terms of the practice patterns and the data that's coming out. At Anderson, we follow the data. If we're treating patients off clinical trial, then we follow the data. So, and our practice patterns at Anderson do reflect, for the most part, what the data indicate for treatment and what's reflected in the NCCN guidelines. So, for example, patients who have an unmutated V gene and are needing their first-line therapy will be more inclined to treat those with a BTK inhibitor-based therapy. And we will use chemoimmunotherapy, particularly FCR, particularly for patients who have a mutated V gene. Now, this distinction between mutated versus unmutated V gene and tailoring treatment with regard to that have not yet fully been incorporated into the guidelines. But I think probably at the next meeting that will happen, because that data was a report from the MD Anderson where patients who had the plateau on their progression-free survival curve were among the patients who have a mutated V gene who get FCR. The Germans have confirmed that data independently in randomized trials. So there's clearly plenty of data that would support that distinction and approach for management for those patients.
Yeah, the question regarding first-line maintenance therapy is a good one, but perhaps one that's becoming less relevant now that drugs like ibrutinib are increasingly being used. That said, there have been some large studies, including the German CLL group study that looked at lenalidomide as a consolidation or maintenance therapy after frontline chemoimmunotherapy. This study did show a reduction in risk of progression and improvement in responses for some patients. And so I think it does show that lenalidomide is an option for patients who have residual disease after frontline chemoimmunotherapy. However, it's also notable that the patients that received lenalidomide in that trial were the minority. Most patients either had very little residual disease or did not have the adverse prognostic factors that would have qualified them for lenalidomide. So I think that regimen, the continuation with lenalidomide, does not apply to all or many patients. But it is something that one can consider, perhaps for patients that had to stop chemoimmunotherapy early due to toxicity.